Good afternoon, our dear students. I want to ask you sorry for some lating because I have a problem with light, with energy and internet here. That's why during 15 minutes I'm trying to switch on something and to do it from my phone. Because of difficult situation, we have some problems with energy, and unfortunately I'm have to start not in time but in future. I'm going to be maybe more prepared, and all lectures, all classes and practical and lectures will be in time. Today we continue our cycle of lectures that connected with internal medicine and especially the cycle of endocrinology. Those week we had a lecture about thyroid gland disease. I hope it was interesting. I hope it was useful for you, for your knowledges and for your preparation to practical classes and in future to your exams. And today we have one more very interesting lecture from this cycle. It connected with very important, one of the most often disorders in internal medicine in general, that it is multi-organic, multi-systemic. It connected with all fields of medicine at all. That's why every doctor, any specialty should know enough information about this disorder. And name of this disorder, diabetes mellitus. It is a topic of our today's lecture. Let's start from the plan of lecture. We will give definition. We shortly discuss epidemiology, mechanisms, classification, clinical presentation, diagnosis, treatment, prognosis, and prophylaxis of diabetes mellitus. Let's give definition. Diabetes mellitus, or diabetes, shortly we usually name it. It is a group of chronic, often debilitating, sometimes fatal, incurable, costly, and increasing but largely preventable non-communicable metabolic diseases that causes the high blood sugar, glucose levels, when the body is unable to produce or effectively use insulin, with unique multi-system complications of microvascular endpoints, including retinopathy, nephropathy, neuropathy, and macrovascular endpoints in forms of ischemic heart disease, stroke, and peripheral vascular disease. We have three main types. We have much more types. I will say you a little about it, but three main types that we usually see in real clinic and we usually discuss in diabetes mellitus. It is type 1 diabetes mellitus, or insulin-dependent diabetes mellitus, or juvenile diabetes mellitus. It results from the pancreas failure to produce enough insulin. It is disorder with deficit, usually it is absolute deficit, when pancreas enable produce insulin. Next type, we name it type 2 diabetes mellitus, or non-insulin dependent diabetes, or adult onset diabetes. It begins with insulin resistance when body cells fail to respond to insulin properly. Gestational occurs when pregnant women without previous history of diabetes mellitus develop high blood sugar. Epidemiology. Diabetes, it is one of the most common endocrine disorders, affecting almost 6% of all world's population. The number of patients will reach 300 million in year 2025. More than 97% of these patients will have diabetes mellitus type 2. Here you see prevalence of diabetes in different countries. It is a little bit different. I will not stop. Let's discuss risk factors. For diabetes mellitus type 2, some of them the same for two types of diabetes, but some of them are different because it is absolutely other two different diseases. Type 1, it is family history. It is environmental factor, especially exposure of viral illness. The presence of damaging immune system cells, or we name it autoantibodies, dietary factors like low vitamin D consumption, early exposure of cow's milk formula, and exposure to cereals before 4 months of age. And geography, the northern countries like Finland, Sweden, they're more sensitive for diabetes prevalence. For type 2 diabetes mellitus, it is family history. It is a race. Researchers showed us that blacks, Hispanics, American Indians, and Asian Americans are more sensitive to diabetes mellitus type 2. Age. Risk of diabetes mellitus type 2 increases with age. It is gestational diabetes. It is polycystic ovary syndrome in women, high blood pressure, abnormal cholesterol, and triglyceride levels. For gestational diabetes, risk factors include family or personal history. It is a race, black, Hispanic, American or Asian, American Indian or Asian, and more likely to develop gestational diabetes, the same with type 2 diabetes. It is an age, woman older 25 at increased risk, and weight. Being overweight before pregnancy increases risk of gestational diabetes. Etiology. Today I will stop very quickly on main moments because diabetes it is a huge nosology. It is a very big, it is a whole science, diabetology. That's why I don't have possibility to explain you everything during 2 hours of lecture, but I'm trying to stop on most important things and all other for yourself working, maybe with the slide, with your books, with guidelines in preparation to practical classes. Etiology of type 1 diabetes. It characterized by loss of insulin-producing beta cells of the islets of Langerhans in the pancreas, leading to insulin deficiency. The majority of type 1 diabetes is one of immune-mediated nature, in which a T cells-mediated autoimmune attack leads to the loss of beta cells and thus insulin. Sensitivity and responsiveness to insulin are usually normal in this patient in type 1, especially in early stages. Type 1 diabetes can affect children or adults, but was traditionally termed juvenile diabetes because it is typical more younger age. Because of a majority of these diabetes cases were in children, but not all in adults, it's possible too. Type 1 can be accompanied by irregular or unpredictable high blood sugar levels, frequently with ketosis and sometimes with serious blood sugar levels. Type 1 is partially inherited with multiple genes, including certain HLA genotypes, and can be triggered by one or more environmental factors, such as viral infection or diet. Type 2 diabetes mellitus, characterized by insulin resistance. Pancreas gives enough insulin, but cells are not able to sense and to take insulin, to take glucose through insulin. We name that they are resistant cells, and we name this diabetes insulin resistant. It may be combined with relatively reduced insulin secretion, especially in more late stages. The defective responsiveness of body tissues to insulin is believed to involve the insulin receptor. In the early stage of type 2, the predominant abnormality is reduced insulin sensitivity. Type 2 diabetes mellitus is due primarily to lifestyle factors and genetics. Obesity, lack of physical activity, poor diet, stress, urbanization. Dietary factors also influence the risk of developing type 2 diabetes, like sugar-sweetened drinks, saturated fats, trans fatty acid, white rice, etc. Gestational diabetes. Etiology of it. in several respects involving a combination to relatively inadequate insulin secretion and responsiveness and occur in 10% of all pregnancy. It is quite often. After pregnancy, approximately 5–10% of women with gestational diabetes found in future to have more commonly type 2 diabetes. Gestational diabetes is fully treatable but requires careful medical supervision through the pregnancy. Gestational diabetes mellitus can damage the health of the fetus, mother, and risks to the baby include macrosomia, high birth weight, congenital heart and central nervous system abnormalities, skeletal abnormalities, respiratory distress syndrome, and red blood cell destruction. Mechanisms. For type 1, we told that it is insulin deficiency from pancreas. By why? Pancreas got it dysfunction. Usually it is result of autoimmune inflammatory lymphocytic infiltration with destruction of insulin secreting beta cells of the islets of Langerhans in pancreas. As beta cell mass declines, insulin secretion decreases until the available insulin no longer is adequate to maintain normal blood glucose level in type 1 diabetes mellitus. After 80–90% of beta cells are destroyed, hyperglycemia develops and diabetes may be diagnosed. It's what I told about absolute it, because pancreas has a very good compensatory mechanism, and if it is partial deficit of beta cells function, it is compensated, it will be no hyperglycemia. And we see the clinic of diabetes mellitus type 1 when it lost more than 80–90% of all beta cells. Polymorphism of class 2 human leukocyte antigen genes that encode DR and DQ is a major genetic determinant of type 1 diabetes mellitus. Here you see scheme of this autoimmune response. Who need it, please stop and walk with this scheme. Type 1 and neuropathy. You know that diabetes is mostly danger due to its complications. And one of serious complication we name neuropathy. What the mechanism of it? It can be sensory and autonomic neuropathy in people with diabetes mellitus and caused by axonal degeneration and segmental demyelination. Many factors are involved, including the accumulation of sorbitol in peripheral sensory nerves from sustained hyperglycemia. Motor neuropathy and cranial motor neuropathy result from vascular disease in blood vessels supplying nerves. Microvascular disease causes multiple pathologic complications in people with diabetes mellitus. Hyaline atherosclerosis and characteristic pattern of wall thickening of small arterioles and capillaries is widespread and is responsible for ischemic changes in the kidney, retina, brain, and peripheral nerves. Angiopathy. Here I describe type 1 angiopathy, type 1 and neuropathy, and really it is the most frightful clinical picture of complications in type 1, but all this mechanism connected with other types of diabetes. Atherosclerosis of the main retinal arteries and their intrarenal branches causes chronic nephron ischemia. Vitamin D deficiency as an important independent predictor of development of coronary artery calcification in individuals with type 1 diabetes mellitus. Here you see a scheme of progressing on angiopathy in diabetes mellitus. Diabetes and nephropathy, yes, primarily with type 1, but possibly with all types. In the kidneys, the characteristic wall thickening of small arterioles and capillaries leads to diabetic nephropathy, which is characterized by proteinuria, glomerular hyalinization, Kimmel-Stell-Wilson, we name this picture syndrome of Kimmel-Stell-Wilson, and chronic renal failure. Exacerbated expression of cytokines such as tumor growth factor beta-1 is part of pathophysiology of glomerulosclerosis, which begins early in course of diabetic nephropathy. Single nucleotide polymorphism affecting the factors involved of its pathogenesis appear to influence the risk of diabetic nephropathy in different people with type 1 diabetes mellitus. And here you see it is nearly history of nephropathy in type 1 diabetes mellitus. In different people it can be quicker, it can be longer, it depends on compensation, it depends on severity, it depends of treatment and compliance to treatment from the patient, but nearly in middle range it is the same. That during 15-20 years it goes from normoalbuminuria to macroalbuminuria, and if it goes to macroalbuminuria, the process becomes more rapid. In 4-5 years it leads to azotemia, and in 1 year it is end-stage renal disease. And here you see as to histological comparison of healthy glomerulus and glomerulus in diabetic nephropathy, what we told this picture of Kimmel-Stell-Wilson. One can notice an augmentation, you see, of mesangial matrix in diabetic nephropathy. Okay, now we have such term like double diabetes. What it means? In areas where rates of type 2 diabetes and obesity are very high, yes, usually it is quite developed countries, individuals with type 1 diabetes mellitus may share genetic and environmental factors that lead to their exhibiting type 2 diabetes features, such as reduced insulin sensitivity. If we see both this syndrome, insulin deficiency and insulin resistance, signs of type 1 and type 2, we name it double diabetes. Mechanisms. For type 2 diabetes, it is characterized by combination of peripheral insulin resistance and inadequate insulin secretion by pancreatic beta cells. Yes, we talked about it in definition. Here, insulin resistance, which can be attributed to elevated levels of free fatty acids and pro-inflammatory cytokines in plasma, leads to decreased glucose transport into muscle cells, elevated hepatic glucose production, and increased breakdown of fat. A role of excess glucagon cannot be underestimated. We don't forget about other hormones of pancreas. Indeed, type 2 diabetes is an islet paracrinopathy in which the reciprocal relationship between the glucagon-secreting alpha cells and insulin-secreting beta cells are lost, leading to hyperglucagonemia and hence of consequent hyperglycemia. With prolonged diabetes, atrophy of the pancreas may occur with both deficit as insulin as glucagon. Here a scheme of abnormal glucose metabolism. I don't have time for it. Beta cells dysfunction. It is secondary but